All right, good afternoon, everyone. On behalf of CME Outfitters, I want to welcome you to this webinar. It's called Intercepting Inequities, Strategies for Improving PrEP Uptake Among Black Americans. And this program is supported by an educational grant from Gilead Sciences, Incorporated. My name is Dr. David Malbranch. I'm an internal medicine, sexual health, and HIV expert based here in the wonderful city of Atlanta, Georgia. And today I'm joined by the illustrious, the famous, the world-renowned Dr. Quentin Robinson, who is an infectious disease specialist at Absolute Care Medical Center and Pharmacy in Atlanta, Georgia. Quentin, welcome to our program today.
Thank you. Thank you.
And thank you for joining us. Okay, so the learning objective for today, and this will be a half-hour session, is we're going to be addressing racial disparities or racial inequities in the initiation of PrEP among Black Americans by initiating two new strategies for HIV testing and prevention into your clinical workflow. And we're going to start with a patient case that you're going to see is going to be presented in video format with two simulated participants, a physician and a patient. And for this patient case, it's Derek. He's a 24-year-old man who's in a monogamous relationship with a male partner who is living with HIV and currently not virally suppressed. He reports that his condom use with anal sex has been routine, but admittedly not 100%. And Derek is not living with HIV currently. He has an unremarkable medical history and no history of STIs. He currently comes to you seeking a prescription for PrEP. So in this scenario, you're watching as the provider and he's coming in. So let's roll the tape and show this video right quick.
Hello, Derek. I haven't seen you in a while. I hope you've been well and safe during these crazy times.
Yes, hi, Dr. Jenkins. Yes, I'm well. I'm happy to report. So far, so good. No exposure to COVID. I've been vaccinated for a while now. I haven't even put on any of that COVID weight.
That's great. I wish I could say the same thing about gaining a few extra pounds. So what can I do for you today?
Well, I wanted to talk to you about a prescription for PrEP.
Oh, okay. But you're monogamous and not exposed to multiple partners. So why don't you just use condoms?
Well, we do, but I can't tell you with a straight face that they are 100%. And so that just seems like playing with fire.
Okay. But you know that PrEP doesn't protect you from other infections if this relationship doesn't work out or if you do start playing the field.
Yeah, I do understand.
Okay.
Dr. Jenkins, is there something else going on and that's making you hesitant about PrEP?
All right, Quentin. So we just saw that video with Derek and his medical provider. Initial thoughts, reactions to that?
So I think when I saw it, my first initial reaction was just, to give, Derek kudos for actually coming to his provider asking for PrEP. I think that's one of the things where we definitely need to talk a little bit more about how you can empower patients to request what they need.
Yeah, I think that's a great point. And what I noticed about the video is that basically they were all happy and chummy for a little bit. And then as soon as he mentioned PrEP, it took a left turn. And all of a sudden the provider kind of mentioned some other things and kind of discouraged him. And you could see his response was a very visceral one. Yeah. Is this a common scenario that you've heard from other patients or you've seen other patients experience in your practice?
Yeah, I definitely have seen it. Patients, because as an HIV specialist, I usually see patients who are living with HIV. So I do have a significant number of patients who come to me for prevention. And then we, ask that question, well, have you had this conversation with your primary care provider? And, some of them, their response was, well, I brought it up, but they didn't seem comfortable talking about it. Or I had one patient say, well, they don't like to talk about things down there. And using those words is what the doctor said. So definitely, I've heard stories like that where they've kind of been, discouraged or kind of turned off from a previous provider.
All right. Yeah. Unfortunately, it's a more common scenario than we want to admit. So let's have you talk a little bit about some of the structural barriers that we see to PrEP as far as patients coming into medical spaces.
Exactly. So, with this conversation this afternoon, we're specifically talking about PrEP adoption amongst Black Americans. And we know just from prescription data out there that the growth of PrEP is slower among racial and ethnic minorities, specifically Black people. And a lot of that can be attributed to experiences of homophobia in healthcare, some uncomfortable conversations about sex where the provider just doesn't, understand the language or comfortable talking about it. You talk about racism in healthcare and, even more broader, systemic racism or structural racism in terms of how healthcare systems are set up to either discourage or have, specifically Black Americans kind of not seeking healthcare. Then we talk about other things like physical barriers, specifically looking at those South and rural areas. Some patients have to travel an hour or 2 hours to see a provider who's comfortable prescribing PrEP because the providers in their community either don't know about it or just don't have those conversations. And then the other social determinants of health, inadequate housing, food insecurity, conversations about sexual health in general can foster some distrust between providers and patients, and that impacts the communication and specifically some shared decision making. And then talking about it from the prescriber perspective, what are these deterrents of PrEP prescribing? And again, it's an undercurrent of kind of what society is. We talk about sexual orientation bias, impacting, PrEP access. Heterosexism is the norm, and so or the supposed norm, and talk about attitudes and stereotypes. So providers may have this preconceived notion that, promiscuity, irresponsible behavior usually are ascribed to men who have sex with men. A lot of providers talk about risk compensation where, they're taking a pill that's going to decrease their risk of getting HIV. They're probably going to use condoms less. And then they have that conversation, they're going to use less condoms. They're going to have more frequent sexual partners. And then this other undercurrent about, well, are you really going to take a pill every day when you're kind of like to prevent sexual transmission of HIV? And then, we have this concept of racial biases, and specifically when we talk about the impact of HIV on communities of color and on Black, MSM, some providers have this bias that because more Black men who have sex with men are being diagnosed with HIV, that they're also engaging in more condomless intercourse. And that honestly is not necessarily the case.
Right. I would agree with that. It's interesting because it actually pans out in this study that came out probably about 3 years ago. And you can see this was actually a study where they examined medical students that were having simulated cases of MSM coming in seeking PrEP. And you can see that a majority of people thought it was, that perceived it to be more likely that they were going to increase condomless sex if they prescribed it. They didn't think so much that they were going to have extra relational sex outside of their primary partners. And they did believe that folks were going to be adherent to PrEP. But you can see on the bottom bar graph there, the intention to prescribe PrEP. About 77% were either probably yes or definitely yes with these simulated patients. But then there were still about 23% that were either maybe or probably not. And that's a good quarter. So you can see where those gaps kind of fall in with that, particularly early in training with medical students. And then when you kind of look at the relationship of what's happening between discrimination, medical distrust among sexual minority males, it's another acronym for men who have sex with men. It starts with discrimination that you can see, systemic racism, sexism, homophobia, transphobia, leading to medical distrust. And then that affects health behaviors. So people won't show up for their visits, decreased willingness to disclose their partner status to provider, their status to the provider, and then the decreased acceptance of new medications or technology that may come out. So it's important to know that it doesn't just exist in a vacuum. It's not just, well, what is their problem that they're not taking PrEP? Sometimes it's the social context and the medical context that is influencing that behavior. And then finally, this was a study that was surveying Black and white MSM that was in a review that I published with Ken Mayer and Allison Agwu, where they talked about conspiracy beliefs that were endorsed more likely by Black than white MSM participants. And these two quotes you can see in this slide: the CDC cannot be trusted to tell gay communities the truth about PrEP. When it comes to PrEP, drug companies are lying and taking advantage of us. You can see that those beliefs and those attitudes don't come out of a vacuum. Again, they're very much based in history and present of things that are going on, why people don't trust medical systems. But it's important as us, as medical providers, to understand that this does exist, listen to our patients' concerns, and then understand that this may be a reason why a lot of Black MSM, cisgendered women, and transgender women really don't want to participate in these trials or engage in PrEP at some point. And I think you're going to talk a little bit about social determinants. Yeah, sorry.
Yeah, definitely. So, it's not just, attitudes and distrust that factor into these inequities. Again, there's these other social determinants, like we mentioned before, specifically like what I see, here in Atlanta and in Georgia, transportation, getting to a provider who's willing to prescribe PrEP. Even though it's a little bit different, when I was a medical student, we had to do rural medicine, and there was a patient living with HIV in Waycross, Georgia, which is like about 4 to 5 hours away. But he would come to Atlanta every 3 months to get his HIV care. So think about, in that community, what's their access to HIV prevention? So are patients having to travel long distances? And then, there are some time constraints. I think that's more of a structure of the healthcare system where they're, forcing providers or having providers see patients in a shorter period of time. And sometimes it's not adequate to have a conversation about sexual health and risk.
Right.
Again, looking at the other part we talked about in Black communities, 38% of, patients have to drive more than an hour to use PrEP. And then people in areas of high density, like in Atlanta, there are a lot of people using PrEP. But if you go outside into the suburbs or in Southern Georgia, you're not going to see that. And then, there's significant limited access to quality medical care and LGBTQ sensitive areas, talking about access to gender affirming hormone therapy, talking about, transgender populations, how is the healthcare system equipped to deal with those circumstances? So those are a lot of the other things that kind of, foster these inequities. So how do we create change? What do we do in the healthcare system as healthcare providers to kind of dissolve these inequities? Education is always key, in the community-based education, to talk about implicit and unconscious bias, help to instill trust in the healthcare system. And again, this falls on the providers to kind of recognize what their biases are and not necessarily see them as a good or a bad thing. It's like, I need to work on changing how I see things or see people or how I react. We can't say this enough. We need more Black healthcare providers in the community as trusted sources of knowledge. I always like to go back to the AAMC study that says there are fewer Black men in medical school now than there were in 1975. So there's a significant need for Black healthcare providers. Really confront head on these, this idea of risk compensation that kind of has providers reluctant to prescribe PrEP. Talking about HIV prevention and talking about sexual health is not going to cause someone to engage in more condomless intercourse or have more frequent partners. Provide positive messaging to patients, in your waiting room, in your social media, in your ads. Talk about, how sexual health is health care and how it's important to help change attitudes and reduce stigma. And then, support those prevention messages through, monitoring and testing. The CDC always gives, guidelines on when to screen and who to screen for HIV, how often to look for STIs. And we really should, as healthcare providers, incorporate that more into kind of our general practice. Because if you're between the ages of 13 and 64, you should have had at least one HIV test in your lifetime.
Right. I couldn't agree more. I want to remind people too that we're going to be coming up on questions in a few minutes. So if you want to start typing up, if you have any questions based on these slides or comments, go ahead and put some of them in now. And then when we stop with these slides, we can actually get to them pretty quickly. So creating a safe and welcoming environment, I think, Quentin, you touched on a lot of the good stuff that we can do and some of the practical approaches we can take, discussing sexual health and PrEP. So it has to be a really patient-centered approach that focuses on health instead of just, we don't want you to get that STI and we don't want to judge you because you're having an STI, but focus more on health and pleasure as a part of sex rather than just disease. And then training staff in cultural sensitive terminology, gender inclusive language, basically cultural humility programs will help along in this process. And this is not just healthcare providers, but everyone in the staff, from the custodian who works there to the front desk person to the navigators, everyone should be part of this training. And then also just building a culture that reassures the patient that the practice is confidential, safe, affirming, and a non-judgmental space. I think when people come into these spaces, if you have the technology, but then it's an uncomfortable and not affirming space, you really can't get the benefit from the advances in science that we've achieved so far. And there's also a lot to be said for healthcare team collaborations that expand the opportunities for PrEP prescribing. So this is just a list, and not all inclusive of everything, but just some of the things that are getting PrEP out there more that I think can address some of these racial inequities that we see based on bias and other structural determinants. So HIV screening and PrEP prescribing in emergency departments, I can't tell you how many times I've seen patients come to me for post-exposure prophylaxis because they went to the ER and the ER denied them. So if we can access that and leverage that, that'll be helpful. Utilizing our amazing resources of qualified NPs and PAs in over 3,000 retail health clinics nationally will help. There are pharmacist-based PrEP initiatives that are amazing, and a quick shout out to Meredith Laura at Emory University and Grady Hospital, who has a great pharmacist PrEP initiative over there that is really helping getting people access to PrEP who otherwise wouldn't get it. And then finally, the opportunity to establish partnerships between medical, public health, and social services. One of the things that's not on this list that I thought about while reading through this is just how telehealth with the pandemic has actually become incorporated. So just people knowing that there are programs that you can do where you can get people on PrEP and either work out home testing of some of the required tests you need, or have them contract, or you send a prescription for whatever labs you need to a local LabCorp or Quest, whatever pharmacy you may have a contract with. So that way people can get it without actually physically having to go to a brick and mortar building. Because like Quentin, you said, transportation sometimes can be a problem, particularly in rural areas. And so this is the last slide before we get into the questions and answers. So we look at the goals, and this is the acronym SMARTS for specific, measurable, attainable, relevant, and timely. So again, addressing the social and structural systemic barriers to PrEP, combating these social biases and not being afraid to talk about them and bring that up and actually reflect them back to people, especially our colleagues who may not realize that they're part of these biases, and people may think they're doing things well. And you're like, no, boo-boo, you're not doing it as well as you think you are. You may have, isolated this person or triggered this person with some of the comments that you made. That's going to be important. Recognizing the presence and manifestations of distrust in the medical community, where that comes from, and listen to it and instead of saying, why do you distrust us? Ask the question, what can we do to foster more trust from these communities? Meeting the patients where they live with positive messaging about PrEP to reduce stigma, and then building a team-based culture that's welcoming, safe, affirming, and non-judgmental. I can't tell you enough. Folks are getting judged enough in their personal lives as it is. The last place they need to be judged is in a medical space that they think is supposed to be welcoming and non-judgmental. All right, so Quentin, we do have a few questions that have already populated here. So I'm gonna start with the first one. We just got another one that popped in, so we should be able to have a robust discussion. So let's jump right in. Recognizing the need for condoms to protect against STIs, do you always lead with PrEP for prevention? And how do you initiate the discussion in patients of color that is culturally sensitive? So two questions that could actually fill up a whole half hour or hour. But let's start with the first one. How do you always lead with PrEP for prevention, given the need of condoms to protect against STIs?
So I actually don't. I'll kind of let the patient lead the conversation. My usual question, especially if it's a prevention or a PrEP focused visit that I'm in, always asks the question of like, so what are you doing to protect yourself from HIV and STI? So I link HIV and STIs together and allow the patient to tell me kind of what their practices are. And then we'll have the conversation of how, PrEP is specifically for HIV prevention. If you are concerned or you consider yourself at risk for other STIs like syphilis, gonorrhea, and chlamydia, then we need to talk about condom usage. So it starts that way. And then conversations that are culturally sensitive, I usually just start with something that's very generic. The tell me about your sex life. Just kind of give me an idea, or like, what are your concerns or what are your ideas surrounding sex and sexual activity and sexual behavior? And kind of, again, let the patient lead that discussion.
Yeah, I think there's not really a platform or a specific template that you can use for quote unquote people of color or Black and brown people or people from different races and ethnicities from yourself. I do what you do, which is kind of, I make it into a problem list. So if there's PrEP, if there's high blood pressure, diabetes, I always put at part of the problem list, tell me a little bit about your sexual health, tell me a little bit about your sex life. And let them kind of expand it. And patients will be very quick to say, I'm gay, I'm this, I'm that, I'm another. And then they start diving into it. And then I can, once they lead, then I can actually answer some more questions with them. So I think that's a good way to start. So another question, I'm a pediatrician and I'm still a little uncomfortable starting this conversation. What advice on a non-awkward opening about PrEP? Good question.
So one, I just want to say kudos for a pediatrician actually being interested in starting this conversation. I've come across so many who actually don't or are afraid. But I think it's just kind of, similar to the previous question, just kind of let them talk, ask them all of the things. So if you're dealing with an adolescent, someone who's 14 or 15 years old, start a question of just something very generic. Well, what do you do in your free time? What are your ideas around sex? Have you thought about sex? Are you having sex? Have you talked with your peers about sex? And just really, not being afraid to open that door, because most times, we've mentioned a study before, even though it was more with adults, where patients feel that their provider, doesn't want to talk about sex, and they do, but providers feel that patients don't want to talk about it, so they don't bring it up. So nobody brings it up in the visit because they have this impression that neither one of them want to talk about it, but both of them want to talk about it.
Right. And I think it's tough for pediatricians because you almost land the role of being like a parent outside of, a patient's home. And so I think, they may be scared to talk to their parents about it. So create the context. And you can also, like, not only to some of the cues that Quentin mentioned, but you could also put in some things, kind of brochures or some other things like around the clinic that talks about PrEP or mentions, like, ask me about sexual health, so that when you're not in the room, but the patient's in there between being triaged and seeing you, they can read that and they can read a big sign that says, ask about your sexual health. And then even if they are 14, 15, they may be thinking about it, but then also it is on us to bring up that conversation because many people may be scared. All right, next question. What are your top 3 points of emphasis about the importance of adherence that you use with your patients?
So for me, it's difficult to come up with 3, but I'll say number 1 is, if you take it, it works. I mean, it's just plain and simple. If I can repeat that 3 times, if you take it, it works. Adherence is the key to HIV prevention. All of the studies that looked at, PrEP, the biggest takeaway from most of them was like, if you took it every day or nearly every day, your risk of acquiring HIV was significantly decreased. And I really can't think of anything else other than, like, I think for me, that's the one thing right there. If you emphasize, if you take it every day, and make it part of your routine, that it works.
It works. I usually just say, I ask them, like, what do you do every day? What's part of your normal routine? And I'll even say, like, really things that I would say around my friends. I was like, you brush your teeth every day, right? You wash your ass every day. Where would you put your pills? Where your pills gonna be? So find a way to keep that, the pill box near there. Or if you have a keychain, put a couple pills in there. So if you forget when you first leave the house, and then you remember as you're leaving the house going about your day, you can look in that keychain and say, oh, I have an extra pill here. Some patients I know do that. So I think all those are good recommendations. But yes, you're absolutely right with the, if it works, if you take it, it works. All right. Can you please address PrEP and gender hormone therapy? Are you concerned about drug-drug interactions?
So this question comes up a lot, and when we look at the studies that were done for PrEP, they did include persons of trans experience, particularly transgender women, and a significant proportion of those transgender women were on gender-affirming therapy. So there really are not any significant drug-drug interactions with gender-affirming therapy. So if someone is on hormone therapy for transitioning and they want to be on a particular drug for HIV prevention, is absolutely safe. There are no drug interactions, and I usually emphasize that up front. I actually bring that up in the visit with my persons of trans experience. I was like, if you are concerned about, there really are no concerns that you really should have, so take it every day.
Okay. Do you typically only prescribe a 3-month supply of PrEP to be sure they come back for testing?
Absolutely. But I do have a few patients who I probably will have them come back every 6 months, but that's after an established relationship. If you're in a monogamous relationship with someone who's also living with HIV, you don't have any other sexual partners, the one that comes to mind right now, I actually see him for PrEP and I see his partner, or actually his husband, for HIV treatment. And, their visits are completely separate. And I ask them both the same questions. Are you having sex with someone else other than your husband? Are there, other people involved in the relationship or in the bedroom? And for that particular PrEP patient, if I develop that relationship, I'll have them come back every 2 months. But most of them, when we talk about 3-month supply of medications and an HIV test every 3 months, most of them have no problem with that.
Absolutely. Yeah, I think the point comes across too that it depends on the patient and the length of your relationship. I think 3 months is a good meter to have them follow up that first time in person and then see kind of where things go from there. And if they're like, Doc, I'd really be better, I'm going to take this every day, give me 6 months, then you can kind of go if you feel that they'll come back for the labs, because that's a huge part of making sure that they're safe and that they continue to be HIV negative as they move along. I'm going to put the next 2 questions together because they kind of run together. How do you address conspiracy theories among your patients when discussing PrEP? And then also, what can we do to foster more trust?
So for me, in addressing conspiracy theories, actually, the first thing is validate that patient's concerns. Let them know that you hear them and you understand where they're coming from, and listen to what their concerns are, and then just present them with the facts, but allow the patient to articulate what their concerns are, even if they're conspiracy theories and, it's something that's completely off the wall and from outer space that makes no sense. Allow that person to articulate what their concerns are and, validate what they're feeling and validate their concerns. And then you can take it piece by piece and just say, hey, well, actually, this is this situation and this is what actually occurs. And then providing resources. I think, that way you can, that also helps to foster trust, is just by listening and then providing them with trusted resources, and make sure that those trusted resources are in language that, the patient can understand. The CDC is a great resource, but make sure you're using the patient education side and not the side for clinical providers, because it is a little bit different, and that plain language makes it so much simpler.
Right. I would just add to that, Dr. Oni Blackstock in New York City does a great thing with motivational interviewing, where she says, listen, validate, and then ask if it's okay, ask permission. Is it okay if I give you some additional information about this? Not to just shut it down or be like, you're peddling conspiracy theories or you're prone to misinformation. Don't do that. But listen to them, like you said, and then invite them in to give them some additional information that they can consider. All right, next question. I'm a medical student. What advice can you give me about interacting with patients about PrEP, or do we let patients start the discussion?
So great that a medical student is listening. And I would say, from even my experience, I used to precept first-year med students. So I would purposefully bring them into the clinic with me and kind of show them how you do that. So it's one of those things, you learn in medical school, going through Bates, your clinical textbook on clinical exam, to talk about a sexual history. So if you make it part of every single visit with every single patient, there isn't anything special that you have to do. And I would hesitate to allow the patient to lead the conversation and at least initiate, because again, some patients may not know how to initiate the conversation. They may be hesitant. And if you've not, started it with open-ended questions and allowing them to kind of come in, it may be a little bit difficult. But I would say just make it routine. It's part of what you do with every single patient you see in every clinical interaction.
Yeah, I think that's some great advice. I'll go through these last 3 very quickly because we only have a minute or 2 left. If they miss a dose, what do you recommend? Take it immediately, even if it means 2 doses within an hour.
So if they miss a dose, what I usually recommend is, if there's a significant amount of time between it, if there's more than, 12 to 16 hours between the time that they missed, I'll say, go ahead and take your next dose. If you've missed a dose, and honestly, if you're not planning on having sex within the next 24 to 48 hours, you're okay to have missed that one dose, but just kind of make sure that you kind of catch up with that next one. You don't necessarily have to take 2 doses within an hour.
Right. I'm going to squeeze one last one in, and then there's another one that I do want to answer because it's an important question about if a teen's on PrEP without a mother's knowledge. how do you address the mother? But let's go to this one question, then we're going to get back to that other one and we'll get an answer to you. Do you know if there are long-acting PrEP of any kind in development to help with adherence?
Great question.
Right.
So there actually are several forms of long-acting PrEP in development. And the thing is, I don't know if it will help with adherence because again, adherence is an individualized thing. However, they're both oral, injectable, and implantable long-acting PrEP in development. So there are actually multiple modalities of long-acting PrEP in development. And for those people who just don't like taking pills, or I think our first discussion we talked about those persons who don't have access. There are several hours or several hundreds of miles away from a provider. Long-acting PrEP may be a fantastic option for them.
And the injectable one may be FDA approved by January or February. So look out for that of just next year. So keep your eyes open. Anyway, Dr. Q, thank you so much again. It's always a joy to do all this stuff with you. For the audience, thank you for your questions and participation. And for any additional CME or CE activities, please check out the CME Outfitters website at www.cmeoutfitters.com. For patient education, the HIV patient education section has a lot of resources, videos, and downloadable resources to share with your patients. Stay safe, and thank you again for participating and providing wonderful care to your patients. Have a good weekend.